Again, good morning. I passed out the PowerPoint presentation on invasive cardiac procedures. This is from your chapter 25, and it's part of the objectives for y'all to meet during this unit prior to your next exam. So I'm just going to briefly talk about nursing theory, which guides our nursing practice. In this case, I'm using Orm's self-care theory. Central concepts that revolve around nursing theory and are incorporated in this class include caring for human beings with cardiovascular issues, utilizing procedures that will help improve their health status, and nursing through patient education. So patient education is key for this presentation. Orm's self-care theory emphasizes the importance of identifying patient education, needs, and providing helpful, informative interventions to promote fulfillment of patient self-care needs. So for our patients to meet their self-care needs, we have to be able to provide them the right tools and have the knowledge of the test that they're going to take and be able to explain that to them so in a way that they understand. The objectives for this class are listed because, again, the numerous advances and improvements in cardiac imaging, nurses should know about the vast array of diagnostic testing that a patient may undergo. Nurses play a key role in the safe administration of these tests by educating the patients about the indication for their testing. Nurses are responsible to educate on the purpose, what to expect, and any possible side effects related to the exam before the procedure. So what are some exams that you're familiar with to assess cardiovascular function that you ran across during this clinical or this class? EKG, very common one, yes. Anybody else? Echocardiograph, yes, very good. So before today, y'all had probably an assignment or videos to look at probably on Blackboard or to read the assigned chapter. Okay, so just for fun, a matching game here. So for cardiac cath, what would y'all choose over here on this side? Okay, what about Holter monitor? Heart attack? BNP?
Indication of HL.
Indication is okay. And dobutamine? ECG?
Shows electrical activity of the heart.
And G? Okay, so we're going to go through the presentation, and at the end we'll review those again. Okay? To start out with, blood tests are sent to lab. They're very important indicators of clients who have a risk of coronary artery disease, high risk, and then of course to determine if they've had an MI. So to assist in making the diagnosis, to screen for risk factors associated with CAD, they establish a baseline. So you always want to have blood work as a baseline before any type of procedure. They also they help monitor the response to therapeutic interventions. So if what we did for that client didn't work. And then it assesses for abnormalities in the blood that affect the prognosis also. So the cardiac biomarker analysis, you see them listed to evaluate for MI diagnosis. Usually these, when the heart cells become necrotic from prolonged ischemia or trauma, they release specific enzymes. And these enzymes go into the circulatory system through and so when you draw the blood work, these will be elevated. Okay? The CK is always elevated with skeletal muscle injury. Okay? and it's required to detect heart injury. However, your most indicative, okay, of heart damage is your troponin. So troponin is usually not detectable without heart injury. So if the patient had an MI, their heart has ischemia, they had infarct, troponin will be elevated. Other blood tests done, your lipid profile. And which are probably familiar with the values, I'll just go over them as I go through. But they help evaluate the risk of CAD. They're usually obtained after a 12-hour fast. And 12-hour. So patients should be fasting for 12 hours before this blood work for it to be accurate. Just a quick review, cholesterol and triglycerides are transported in the blood by combining with plasma proteins to form lipoproteins. And of course, there is a correlation. There's an increase in the ratio for LDL and HDL, then there's an increased risk of coronary artery disease, which throughout I'll use CAD, okay? Coronary artery disease. So lipid is required for hormone synthesis and cell membrane formation. It's found in the brain and nerve tissue, and we obtain it through our diet, animal products, and it's synthesized in the liver. Factors that contribute to the variations, everybody's different. You could have a slim person and their cholesterol is super high, right? Because genetics play a big part. Age, gender, their diet, their exercise pattern, menopause, tobacco use, and stress levels. Okay? The LDL normal is it's less than 160, and the goal for a client that has CAD or diabetes is less than 70, so that is a big difference. Again, if it's elevated, there's an increased risk of CAD. Primary, so your LDL, they're the primary transporters of cholesterol and triglycerides into the cell. Therefore, they're harmful. This is known as your what type of cholesterol? Your bad cholesterol. And then, so they're harmful. It's a harmful effect because they deposit in your arterial walls. The HDL, normal, 35 to 70 for men, 35 to 85 for women. And it has an inverse relationship, which y'all probably know this too. If the HDL, we want the HDL to be high, yes. And this, so the goal for CAD is greater than 40. Okay? It has a protective action. This is your good cholesterol. It transports cholesterol away from the cells, from the tissues. And it takes it to the liver for excretion. Triglycerides, okay? The goal is 100 to 200. The free fatty acid and glycerol. It's stored in your adipose tissue, where we don't want it to be. But it is a source of energy, and it has a direct correlation with LDL. And an inverse correlation, an inverse with HDL. So your next one listed here is your BNP. It's a neurohormone that regulates blood pressure and fluid volume. It's secreted from the ventricles in response to increased preload with resulting elevated ventricular pressure. So the BNP is used as a diagnostic or monitoring tool for heart failure. If it's greater than 100, then it indicates heart failure. I think I got that one right on the matching.
You said if it's greater than 100?
Yes, 100, it indicates heart failure.
Thank you.
Other reasons they may be elevated if a person had an MI or a pulmonary embolism, or even erectile dysfunction, which I thought was pretty interesting. I didn't know that. That's something I learned. CRP, your C-reactive protein, is a neurohormone produced by the liver in response to systemic inflammation. So if this is elevated, then it increases the risk of the development or progression of arteriosclerosis. The homocysteine is an amino acid linked to the development of arteriosclerosis also. So that's why it's on there, and then so it'll be a blood work done. Since it damages the endothelial lining of arteries and promotes thrombus formation. If elevated, again, increased risk of CAD, stroke, and PVD. However, it's not an independent predictor of CAD. And this one's also obtained after a 12-hour fast for it to be accurate. So moving on to imaging, okay? You're well-known probably with the chest x-ray. It determines the size and the contour of the heart, the position of the heart. It demonstrates physiological alterations in the pulmonary circulation. It may diagnose heart failure, but not MI. And you use it to confirm placement of your central lines also, or pacemakers. Fluoroscopy is an X-ray imaging technique, and it's used using a movable X-ray source. It allows visualization of the heart on a screen. Cardiac and vascular pulsations and unusual cardiac contours are also visualized. And it's used with the cardiac cath. When a cardiac cath is done, this is what they use, fluoroscopy, to help guide the insertion of the arterial and venous catheter. Someone mentioned earlier the ECG, very common. Ms. Berg started her lecture last week after your exam on giving the definition of ECG. Basically, like the graphic representation of the electrical current of the heart. When clients are placed on this continuous ECG monitoring, you must inform them that its purpose, why it's used, and caution them that it doesn't detect symptoms like shortness of breath or chest pain, or other ACS symptoms, acute coronary symptoms. So again, teaching them what to report because this machine will detect it. We used the disposable electrodes. She talked about the position, right? The snow over grass, and then the smoke over fire, and then your chocolate in the middle, right? So very important where you place the electrodes on the chest. Again, they are disposable. You don't want to place them over a pacemaker or implanted or anything like that. Your standard ECG is composed of 12 leads, so just meaning it gives you 12 different views. Main thing we use it to diagnose MI or other conduction abnormalities, other dysrhythmias. So examples of your continuous ECG monitoring include the hardwired cardiac monitoring. So this is that bedside monitor that you see in the ICU during your rotation. So I know you're getting very familiar with that. It's used to continuously observe the heart for dysrhythmias and conduction disorders using 1 or 2 ECG leads. And then I know Ms. Berg explained, right, if it's on the top, that's why you see that PQRS, facing up, and then the bottom lead facing down. Okay, so again, critical care units monitor the hemodynamic parameters. So on there, again, what do you see on that monitor when you go on the unit? What does it monitor?
Your heart rhythm.
Heart rate, rhythm,
Blood pressure.
blood pressure, yes. Okay, so respiratory, yes. O2, respiration, okay, good. Telemetry. So telemetry is that little box, put the batteries in, and the patient, you see the patient walking around on the unit, ambulating with in the pouch, right? But it transmits radio waves from that battery operated transmitter to a central bank of monitors. So I know at the hospital I work at, they have a central tele, so they're able to just sit there and monitor all the patients and report to the nurse. Lead systems, it depends on the clinical setting, wherever you're going to be at, but it determines the number of the lead options monitoring. The most common selected are the lead 2, atrial repolarization, which is the P wave, and lead B1, ventricular depolarization. For ambulatory, the word says it all. It's for the outpatient setting, and it's used to identify the etiology of symptoms caused by dysrhythmias. So what would be a common ambulatory device that they could use for ECG monitoring? A Holter monitor, that's right. So it's worn for about 24 hours. Patient's able to keep a log, a diary on their activity, on their symptoms, and then they'll come back, right, at 24 hours and turn it in, so they can upload the analysis on the computer. Okay. Transtelephonic, very, I guess, more advanced, more tech savvy. A specific lead system for transmitting signals. It's attached to a landline telephone mouthpiece over the transmitter box, which is recorded and evaluated at a remote location, doctor's office, or a community agency. And again, it's used to diagnose dysrhythmias or evaluate pacemaker and implantable cardioverter defibrillator function. Your wireless mobile, a small sensing device that transmits each heartbeat to a small monitor. It's lightweight, and this one's 24/7 also. And it automatically transmits the client's ECG to a monitoring center through a client's telephone or through a wireless communication system when outside the home. It enhances detection and early treatment of dysrhythmia prior to having serious signs and symptoms. Yes. Yes, ma'am. I thought it was pretty neat. I've never seen one. Okay, so what's your role in teaching these patients, about cardiac monitoring? Always, of course, ensure client safety. You want to prep the skin, clean with alcohol, and you'll probably have a chance to do this on these patients, because those electrodes, they wear off or they come off, so just make sure the skin is clean. You don't put it over a bony prominence. So always prepare the skin. Rotate the electrodes. Respond to all alarms. So you'll have alarms that sound off because the electrode fell, or the battery is low, or the leads are loose, right? And then you have your alarms where patients tachycardic, bradycardic, or they have an dysrhythmia. So either alarm, you always want to respond, okay? And what happens, and I want to give you a little homework, when you go to clinical, I want you to observe your nurse and see how she responds to those alarms, okay? Because what happens is, have y'all heard of alarm fatigue? Yeah, they get desensitized, right? Am I saying that word right? Desensitized. So it takes them a longer period to respond sometimes, and this could be fatal for our patients. Or they may miss some important alarm. They probably think it's the battery, and they'll do it later. So just pay attention to that, okay? And just always keep in mind client safe, because that word, desensitized, it does happen with this overexposure of the frequent calls or alarms. Keep lead wire, cables, equipment, all that clean. That's on there. Okay, our next type of non-invasive method to evaluate the response of cardiovascular system is the cardiac stress testing. This is one of the most commonly used methods to assess for CAD. It involves the patient exercising with the exercise stress test. They're physically able to perform. With your pharmacologic stress test, they're giving drugs, vasodilators, that will help mimic the heart. And these are for patients who are physically unable to perform or to exercise. And so the stress testing will increase myocardial demand, and it will be used to determine the presence of ischemia. So again, it'll help determine CAD, the cause of the chest pain, effectiveness if they're already on an antiarrhythmic or anti-anginal medication, and to determine specific goals for a physical fitness program.
I have a question, sorry.
Yes, ma'am.
Which test did you say was for, they get vasodilators if they're not physically able?
Correct. Pharmacologic.
Thank you.
Yes, and we'll touch on that a little bit more. So you want to assess your patient for contraindications. You don't want a patient who can't perform, for these tests, because the complications can be life-threatening. They can have an MI while they're doing the test, go into cardiac arrest, have severe dysrhythmia. So the healthcare provider present during that testing, they need to be ready, right, to perform any type of emergent treatment and have equipment on standby for the advanced cardiac life support. This is a list of the patients you don't want performing this stress test. The exercise stress test, patients walking on a treadmill, they're using a stationary bike. Okay? You want to follow the protocol where, at your facility based on the purpose for the test for your patient and the physical fitness level and the health of the client. So during the test, the patient's monitored with 2 or more ECG leads for heart rate, rhythm, and ischemia changes, blood pressure, skin temp, physical appearance, perceived exertion, and symptoms such as chest pain, shortness of breath, dizziness, cramps, and fatigue. When the test ends, when the patient has reached the target heart rate, or the client started experiencing the signs and symptoms of a heart attack. Cardiac catheterization may be needed if the client develops the symptoms of chest pain, extreme fatigue, a decrease in blood pressure or pulse rate, and serious dysrhythmias, or ST segment changes on the ECG. You can see my little man over there exercising, and he's being monitored. Screen's there. Okay. Healthcare provider in here. Okay, the pharmacologic stress test. Again, it's performed when a patient is physically disabled or deconditioned. Okay. The IV medications given to vasodilate the coronary arteries are the diperdamol and adenosine. So again, they're given to mimic the effects of exercise. They're going to make the heart work. Diperdamol lasts about 15 to 30 minutes. Side effects include chest discomfort, dizziness, headache, flushing, and nausea. Adenosine lasts less than 10 seconds, so it goes in and out quick. And it's the similar side effects as diperdamol, but it's more severe and it subsides rapidly. Is it 5 minutes? Less than 10 seconds for adenosine. Theophylline and other xanthines, such as caffeine, block the effects of these vasodilators. So they must be avoided before the test. I got another one right. So glutamine is a synthetic sympathomimetic agent. Okay? So this is the agent of choice when ECG is used due to its effects in altering myocardial wall motion. And it's usually used for clients with bronchospasm or pulmonary disease that cannot tolerate doses of the theophylline when held. Okay. Your role for a patient who's undergoing a stress test, you want to make sure that they've been MPO for 4 hours before the test. They can take their medications with a sip of water. This is to decrease the risk of aspiration in case they do get nauseated and start vomiting. So medications with a sip of water except beta blockers, digoxin or calcium channel blockers. So if safe, you want to stop these medications 24 to 48 hours before the test. So if given, what happens is they may produce ST segment depression and prevent the patient from reaching their target heart rate. So again, avoid medications containing coffee. If stimulants are ingested prior to the pharmacologic stress test, then that test, it's canceled and they need to reschedule. Okay, for the exercise, again, just help the client by describing how the test will be performed. All those cables, all those monitors, just puts them at ease when you explain. Use the rationale if they're going to have the IV inserted, which they usually do already in the hospital, and what symptoms to report. Review what type of exercise they'll be doing, and just ask for them to put the best effort as they can. And after the test, you'll monitor 10 to 15 minutes. Once stable, they can resume usual activities. The pharmacologic test, again, just instruct them to report any occurrence of signs and symptoms, and the test may take 1 to 3 hours if imaging is performed. Okay, echocardiography. Most frequently used non-invasive cardiovascular diagnostic test. It has high quality imaging, and hemodynamic data is safe, is quick, and usually painless. Requires little preparation unless they're undergoing TEE. TTE. I think someone mentioned that earlier. Okay, and your T, so we're going to talk about it a little bit. Your TTE, again, non-invasive ultrasound. A transducer is used with gel placed on the chest. It involves the transmission of high-frequency sound waves into the heart through the chest, and it records the return signals. Compared to your TEE, it has poor quality of images because it has to go through more tissue with lung and bone. Okay, it does have Doppler techniques, which show the direction and velocity of blood flow through the heart. So it's able to detect leaking valves, valvular regurgitation, and abnormal blood flow between the left and right septum. Okay. So it could be combined, TTE could be combined with the exercise or pharmacological stress test. Usually if there's abnormalities in ventricular wall motion during stress test, but not during rest, there is a highly suggestive, it's highly suggestive of CAD. And further evaluation of, sorry? Yes. So when it's performed with the exercise or pharmacological stress test, if there's abnormalities during the stress test to the heart, during the exercise, then it's more indicative of CAD. So they may require further eval and get a cardiac cath done. Does that answer your question? It's just the exercise versus rest, basically. If there's the abnormalities during exercise, but not during rest, is what I'm trying to explain. It is highly suggestive of CAD. So nursing management, just again explain to the patient. It's usually painless. They're going to have to lay on their left side and hold their breath at times. Okay, and the test may take 30 to 45 minutes. TEE. So this is your transesophageal echocardiography, and it's used to diagnose heart failure, valvular heart disease, and dysrhythmias. It provides a clear image due to the ultrasound waves passing through less tissue. Complications are uncommon, but if they were to occur, they can be serious due to the sedation and impaired swallowing from the topical anesthesia, or due to the insertion or manipulation of the transducer going into the esophagus and the stomach. So here you can see the transducer going down through the mouth, down the esophagus, and it's emitting those sound waves to the heart. And all that image you see on the monitor. Okay, for this procedure, you want to ensure that informed consent is completed. They've been MPO for 6 hours before the test, and that if the client wears partials or full dentures, that they're removed. After the test, you want to assess for the gag reflex. If intact, begin the sips of water. If that's tolerated, you can advance to a pre-procedure diet. Let them know that a sore throat is expected for the next 24 hours. However, they need to report any persistent sore throat, shortness of breath, or dysphagia.
You said shortness of breath, dysphagia, and what else?
Persistent sore throat. Your next type of imaging is a radionuclide. The studies involve the use of radioisotopes to non-invasively evaluate coronary artery perfusion, to detect myocardial ischemia and infarction, and assess the left ventricular function. So these radioisotopes are unstable atoms that give small amounts of energy in the form of gamma rays as they decay. So either the patient can ingest it or it could be given IV, but it requires high-tech machines to perform the radionuclide imaging. Myocardial perfusion is used in combination with the stress test to determine the cause of chest pain, or CAD. It's usually performed after an MI. It takes about 30 minutes. The IV is inserted, you give the radioisotope, electrodes are placed to monitor for the heart rate and rhythm. Your equilibrium radionuclide angiocardiography is abbreviation ERNA, which is the same as the multiple gated acquisition, and you'll see it as MUGA Scanning, it's a non-invasive procedure that uses conventional scintillation camera interface with the computer to record the heart images. Just reassure the patient that no known radiation will cause danger. For these tests, usually they're lying down still for a long time, and they're not supposed to move. The CT scan, it uses X-ray to provide accurate anatomic images of the four chambers of the heart, valves, arteries, veins, and pericardium. It's not used to evaluate myocardial perfusion or valvular function. Your CTA, you use the IV contrast, and it provides better images and improves visualization of the lumen of the artery for stenosis. Your PET scan, again, another non-invasive nuclear cardiovascular imaging technique, and evaluates the severity of CAD by checking myocardial perfusion to help determine treatment. For these tests, again, the nurse must assess for the fear of spaces or claustrophobia. For a PET scan, the radioisotope injected via the IV takes about 1 hour for the body to absorb. Electrodes placed on the chest to monitor heart rate and rhythm. Your MRA examines both physiologic and anatomic properties of the heart. It uses a magnetic field and computer-generated pictures to image the heart and great vessels. It's limited due to the quality of images distorted due to the person breathing, a beating heart, and implanted devices. And let's see, you want to screen for contraindications. Instruct them to remove any metal objects, transdermal patches, and assess again for claustrophobia. Anticipate having a mild sedative ordered. Okay, and just teach them about the loud clanking noise. Maybe provide earplugs or headphones. Let them know that there's a mic in the machine and they can communicate with you or with the staff that's there. So for radionuclide imaging, nurses should assess the patient for adequate hydration because dehydration increases the risk for contrast-induced nephropathy. Patients at greater risk for reactions include those with asthma, a history of reaction to the contrast material, and renal disease. Other risk factors include age 75 or greater, CHF, diabetes, and multiple myeloma. Your electrophysiologic study. Okay, this is an invasive procedure. It's performed in a very equipped, high-tech place with the electrophysiologist to evaluate and treat various dysrhythmias. They're usually conscious but lightly sedated, very similar to your cardiac cath, which we're going to go briefly. So this is, and even your book had a small section on this part, but you can also find more information on chapter 26, pages 724 through 726. A nursing management similar to cardiac cath. Okay. Your cardiac cath gold standard for CAD diagnosis. So this will be covered in your lecture with Ms. Berg for a MI. So we're just going to go through it briefly. It's performed to diagnose coronary artery disease, assess artery patency, determine the extent of arteriosclerosis, and to determine whether revascularization is needed or may be beneficial. Also, pulmonary hypertension, valvular heart disease, and measures the pressures and O2 in all 4 heart chambers. It's commonly performed as outpatient through the femoral radial artery. Bed rest after the test varies depending on the insertion site. It could be 2 to 6 hours. Anticoagulation status, age, obesity, and the size of the catheter used. Usually a smaller catheter is used on the radial. There are 2 types of cardiac cath, include your right, via the right heart, using the antecubital or femoral vein. The right heart cath is usually performed before a left heart cath. It passes through the right side of the heart, through the atrium, ventricle, pulmonary artery, arterioles, and it's relatively safe. The left heart cath passes through the aorta and left ventricle. Coronary angiography is performed to observe the coronary artery anatomy and evaluate degree of arteriosclerosis. There's been research done on that complications are identified for cardiac cath. So it's been resulted that effective nursing management by an application of using a checklist of monitoring their vital signs and all their hemodynamic status improves or it helps prevent these type of complications, having an allergic reaction, vasovagal bleeding, bruising, pseudoaneurysm, or even having an acute MI, and kidney failure induced by contrast. So before the cardiac cath, the client should be MPO 8 to 12 hours. Assess for allergies, right? If they're allergic to seafood, if they've had an allergic reaction to iodine in the past, and anticipate, the doctor prescribing antihistamine or steroid. You want to have blood tests for baseline and to identify any abnormalities before and after, or for after your test. Like your BUN, creatinine, your coags, INR, PT, PTT, H&H, platelets, and electrolytes. So you want to explain to the patient that they may have occasional pounding sensation in their chest, palpitations, extra heartbeats due to the catheter tip touching the endocardium. Oh, this is before. You want to let them know that they may feel palpitations. Correct. Because these patients aren't fully sedated, right? They're consciously sedated. Okay. They may have a sensation to void, okay, because of the contrast. But let them know that it'll subside in about a minute or less. They may be asked to cough. Disrupts the dysrhythmias and clears the contrast agent from the arteries. And to breathe deeply or hold their breath, that helps lower the diaphragm. So they get better visualization of the heart structures. Yes, this is all before. Because during, during the cardiac cath, you ensure again that you have the resuscitation equipment available. Okay. At risk. These patients who are at risk for your contrast agent-induced nephropathy, this is usually reversible. However, they may require dialysis. So the best thing to do is help prevent them going into this state. So pre and post-procedure hydration with IV infusions of saline or sodium bicarb can help prevent them going into the contrast-induced nephropathy.
Can you repeat that again, please?
Yes, so preventive strategies for the high-risk clients. You want to hydrate before and after with IV infusions of saline or sodium bicarb. And the antioxidant acetylcysteine,
Mucomist,
mucomist, yes,
acetylcysteine.
yes, that could be used too. After the cardiac cath, observe for access site, assess the access site for bleeding or hematoma. You want to assess peripheral pulses to whatever extremity was used. Lower extremity, your dorsalis peak, and posterior tibial pulses. Upper extremity, your radial pulse. And usually it's done every 15 minutes for 1 hour, every 30 minutes for 1 hour, and hourly for 4 hours, or until discharge. That's usually for the outpatient study, okay? Inpatient study, you're not going to do it for 3 days or 3 days. Frequent nursing assessments of catheter access site. Very, very important to help catch, right, if they're bruising or bleeding. You want to evaluate the affected extremity for temperature, color, capillary refill, assess for pain, numbness, tingling, and compare the affected extremity with the unaffected extremity. Screen for dysrhythmia. So they'll probably be on a monitor, cardiac monitor afterwards, and assess for apical and peripheral pulses for changes in rate of rhythm. Potential, you want to screen for potential vasovagal response, so if they become bradycardic, blood pressure drops, because they become nauseated due to bladder distension, or discomfort from the manual pressure placed on the insertion site. Bed rest is from 2 to 6 hours with the affected leg straight. You want to elevate the head of the bed no more than 30 degrees. For the radial, when they use the radial axis, and this is usually done in the outpatient setting, bed rest is 2 to 3 hours or until the effects of sedation subside. They're able to sit up quicker than your client with the femoral axis site. And they should avoid sleeping on that arm for about 24 hours. They should avoid repetitive movements to the affected extremity for 24 to 48 hours. Instruct the client to report chest pain, bleeding, or discomfort to the axis site. What lab work would you monitor for contrast-induced nephropathy? Yes. So check serum creatinine levels, very important. Ensure safety, right? At all times, instruct the client, that they cough, that alongside rail, whatever you do in the hospital setting. So I'm going to put a little video just to briefly go over the after repair cardiac cath.
Just to make sure the volume works.
Okay, thank you.
Nurses will continue to monitor your blood pressure, heart rate, and the circulation in your feet, and check the site for bleeding or bruising. You will have to rest in bed for 3 to 6 hours after the sheath is removed. For the first 2 hours, the bed must be flat. After that, the head of the bed can be elevated slightly. Your nurse will elevate it appropriately. You will be instructed and reminded frequently not to lift your head, raise your arms over your head, cross your legs, reach for things at your bedside, or bend the leg where the test was done. Resting allows time for the puncture site to seal over, so there is less chance of bleeding from the site when you are up and about. Your nurse will help you get up for the first time. It is a good idea to sit on the side of the bed for a few minutes before you stand. Report any dizziness, weakness, or discomfort to your nurse. You will be asked to use your fingers to apply pressure to your groin if you cough, sneeze, or laugh. If you feel a warm sensation or sudden sharp pain in the groin or feel a lump at the test site, ring your call bell for a nurse. If you need to empty your bladder or move your bowels while you are on bed rest, a nurse will provide you with a urinal or bedpan. While using the urinal or bedpan and getting on or off the bedpan, you will be asked to apply pressure over the test site. Pressure lessens the chance of bleeding caused by movement. If the site starts to bleed, a nurse or doctor will apply pressure with their hands or with a special clamp to stop the bleeding. Many people have back discomfort when lying flat and still for long periods of time. Tell your nurse if you have any discomfort so she can help you change your position